I have gotten a lot of requests to do a video of this nature. As you know, or don't know, I am an ultrasound tech. That is what my full-time job is. I've been doing it for 8 years, and I have been doing OB for 7.5 years. I have had the chance to work with multiple different doctors who have taught me a ton, and I have had the chance to work with MFM providers, which are high-risk doctors, who have also taught me a ton. And that is where I have learned most of my knowledge, in addition to going to school, obviously, for that. I am a registered tech, which means that I have taken national boards for OB, and then physics, which you have to get registered anyway. So I have notes in front of me here. Today's video is going to be on common abnormal ultrasound findings. So these are things that as techs we see almost on a daily basis, I would say, that seeing them on a daily basis to us are not concerning usually, but as a patient, when you hear something's wrong with your baby, your initial reaction is to freak out, which is totally understandable. But I just want to give you guys some insight on this and hopefully reassure your nerves and let you know that we do see these things all the time. And, 9 times out of 10, it really is nothing. So some of these things you're probably asking, what do we see? These are the most common, I would say. So the most common ones we have are, it's called an echogenic intracardiac focus, choroid plexus cyst, echogenic bowel, renal pyelectasis, single umbilical artery, ventricular megaly, club foot, and cleft lip. Hold on, my kids are knocking. Okay, so sorry. So we're going to kind of go over these things. We're going to go over what they are, what it means. What do you do about it? If there is anything that we can do about it, do you do it before this baby comes, or do you wait until after the baby's born? And then some things that we tell our patients. So the first one that we're going to go over, I think is going to be an echogenic intracardiac focus. Before I get into this though, I do want to preface this with every doctor has their own opinion and every doctor has their own protocol for these things. And first and foremost, you need to trust your doctor and you need to listen to them with whatever they're recommending, with whatever they're telling you. Like I said, every doctor does things differently. So listen to your specific provider and what they recommend. These are just guidelines. These are just things that we've learned. And I'm just passing them on to you. Think of it as a friend. So don't take what I say to your doctor and say, well, this girl on the internet said, because the second you say anything like that, they're going to roll their eyes at you. But this is just friend to friend here, me telling you what I've learned. And then some doctors may recommend that you go see an MFM or a high-risk specialist for what we call a level 2 ultrasound, where they look at things more in depth with what they see. I also need to say that these things alone, or what we call isolated, are usually not concerning. If you start to see these things, if you have an echogenic focus in the heart, if the baby has fluid on the kidneys, if the baby has enlarged ventricles in the brain and a club foot, when they start piling on top of each other, that does get more and more concerning. When it's just one thing. So if your doctor says, hey, your baby has a single umbilical artery, that might be concerning, but it's not as concerning if it's just by itself, because when it's isolated, it's not usually associated with a chromosomal problem. When you get these things that are built up on top of each other is when it becomes more concerning and we start to worry about chromosomal problems, because it's not just an isolated finding, it's multiple things. So when you have these that are isolated, they are not too concerning, but we'll get into each of these individually. So let's start with the echogenic intracardiac focus. Echogenic by definition is anything that is bright on ultrasound. So things that are more dense like bones, those are echogenic. They're bright white on the scan. So you'll see like their long bones and things like that turn up really bright. The spine, anything that is what we call anechoic or black, essentially, is fluid or less dense. So amniotic fluid, blood, cerebrospinal fluid in the brain and down the spinal canal, you can see, and that is going to be black because it is fluid. So echogenic focus in the heart are usually found in the left ventricle of the heart, and it correlates to the calcification of the papillary muscle in that heart. And so we're finding as our technology gets better and better, we're picking these things up. Our resolution is getting so much more clearer, and we're able to penetrate more, so we're seeing these things that have always been there. These calcifications have always been in the papillary muscle. We're just now seeing them because our technology is getting better and better. So we're seeing these echogenic focuses more and more, and realizing that when they're isolated, it's not as concerning. So some numbers here, I will throw out some. We see them in 3 to 4% of normal fetuses. They can be associated with trisomy 21. 18% of babies, trisomy 21 is Down syndrome. 18% of those babies have an echogenic focus. When you are at a higher risk, then it does increase your odds of having a chromosomal problem, advanced maternal age, things like that. Is anything over the age of 35, you're considered advanced maternal age, and that does put you at a higher risk. In a lower risk population, the increase in the risk is usually not substantial and can be considered what we call a normal variant. So just things, like I said, that we're seeing more and more because our technology is getting better and better. So what do we do about it before this baby comes? We want to make sure that that it's truly there, that it's not a false positive. So you want to try and duplicate that image in 2 different fields. You want to try and turn like sagittal, which is a longitudinal view, or transverse view, to make sure that it really is there and that we're not just getting some type of artifact. Look for other markers of malformations that are going to increase your risk. So like I said, clubfoot, pyelectasis, ventriculomegaly, all of these things. If we are seeing more and more and more, that increases our concern substantially. So if other findings are seen, or if the mom is already considered at higher risk for a chromosomal abnormality, then we would recommend genetic counseling or refer you to like an MFM. Postnatally, after baby comes, what do we do about it? Nothing. There is nothing. 9 times out of 10, they've completely resolved. It's just a normal calcification in that muscle layer. So that is our first thing. I do want to say also that it doesn't mean there's anything wrong with the heart. So we don't even recommend doing like a follow-up echo after the baby's born. So that's something to keep in mind. Also, if you are at a higher risk, obviously, like we said, go to get genetic counseling. You can do an amnio. There's a lot of different blood tests now that you can do that test different proteins and cell-free DNA and things like that. So talk to your doctor about what is best for you guys in your situation. The second thing we have is choroid plexus cysts. I hate these things because it's kind of like the echogenic focus. We see them all the time and they are of no significance usually. So what is a choroid plexus cyst? It is a cystic area seen in the lateral ventricles of the brain, and they can be unilateral, or you can have, which is one-sided, or they can be bilateral, which is on both sides. Some numbers for you. We see them in 0.3 to 3.6 of normal fetuses, can be associated with trisomy 18, which is another chromosomal abnormality. 30 to 50% of fetuses with trisomy 18 have choroid plexus cysts. Babies with trisomy 18 also have other findings on ultrasound. So an isolated choroid plexus cysts are more often seen with a normal baby. What do we do about it before this baby comes? Prenatally, we're going to look for other markers. So like with trisomy 18, those babies have clenched fists. They have what we call a strawberry shaped skull. So their skull is misshapen. It's shaped like a strawberry, like it says. these cardiac defects, if the baby has all of these things, then like I said, this is becoming more and more concerning. If other findings are seen, then we would consider you higher risk for a trisomy 18 and would refer you to genetic counseling. Usually they're not seen after 23 weeks. So by 23 weeks, they are almost always resolved by, I would say 32 weeks. It's almost always gone. Postnatally, what do we do? Nothing, again, unless it's a trisomy 18 baby. If it was just an isolated finding, it's not concerning. The choroid plexus, I just was going to explain that a little bit more too. The choroid plexus is a part of the brain, and that is responsible for producing cerebrospinal fluid. And so these cysts are just thought to form there. Too much fluid collection from that. They form these cysts. They resolve almost always on their own. So like I was saying, when you find these choroid plexus cysts, it does not mean that there is anything wrong with the baby's brain. It doesn't mean that they're going to be developmentally delayed. They're not going to be prone to anything other than any other baby that doesn't have these. So they're not of any significance. It doesn't mean there's going to be anything wrong when they're born. And even after birth, we don't even recommend any further follow-up because 9 times out of 10, they've resolved by the time baby's born. Again, if you're at a higher risk for trisomy 18, then obviously you're going to sit down with your doctor and discuss these things further. Echogenic bowel. These are all things, you guys, every time I see these, I'm like, oh, man, because it's like enough to where the patient's going to get concerned, but in our mind, like they're really of no significance. So our next thing is echogenic bowel. Echogenic bowel is remarkably brighter appearance of the bowel in the intestines of the baby. And so the entire intestine or a portion of the intestine may appear more echogenic. It's also called hyperechoic bowel. Numbers, here's some numbers for you guys. It's present in 0.5% of normal babies. The thing with echogenic bowel is there's a few different things that this can indicate. So anytime you see echogenic bowel, this does require further follow-up. It can be associated, again, with Down syndrome. 7 to 42% of babies with Down syndrome have echogenic bowel. It can also be associated with congenital infections. So like CMV, toxo, HSV, parvovirus. These are all things that you're usually tested for prenatally before, at that first appointment. They ask you all these questions, and if you are at a higher risk, they test you for these things. Another time I've seen echogenic bowel, it's associated with cystic fibrosis. So you can have a carrier screen test to see if you are a carrier, and if you are a positive carrier, your spouse needs to be tested as well, or the father of the baby needs to be tested to see if he's a carrier. Also, if both of you guys are carriers, you have a 1 in 4 chance of having a baby with cystic fibrosis. And so then that's where we would I've seen echogenic bowel with babies with cystic fibrosis. It can also be associated with bowel pathology, so like a bowel obstruction, atresia, and other malformations. It can be a benign finding, again, probably related to maternal bleeding, fetal swallowing of blood, things like that. So if there's any type of placenta abruption, that can cause a bleed, and so then that baby can swallow that, and you get the echogenicity in the bowel, and it goes, or in the stomach, passes through to the bowel, and then that's where we see it. So what do we do about it before this baby comes? We want to confirm the finding again, make sure that it truly is there. False positives are so common with this because, like I said, our technology on these machines are just getting better and better. Things are looking more and more echogenic when they're really not as bright as we think. Echogenic bowel, by definition, is when the bowel appears as bright as or brighter than the bones, and so that's how we classify that as echogenic bowel. We want to look for other markers or malformations associated with the chromosomal abnormalities. Again, if we just see the echogenic bowel, it's not as concerning for trisomy 21 than if we have the ventriculomegaly, the club foot, cleft lip, like those renal pyelectasis. keep calling it pyelectasis because it could be pyelectasis or pelviectasis, depending on, there's no difference. Anyway, so again, if you're seeing more and more and more of these things that is concerning, other than just an isolated finding of echogenic bowel, requires further follow-up because there's so many different causes of echogenic bowel. And so you can see, we would send our patients to an MFM, and then they would get a further workup with them. You want to test the blood for CMV, toxo, consider testing for HSV and parvo, because those are things that can cause echogenic bowel as well. And if you do an amniocentesis, the fluid should be sent for a karyotype infection or like CF, karyotype, infection or CF. And then if the workup's negative, do you consider follow-up ultrasound in the 3rd trimester for growth? Yes, absolutely. You can scan again, usually 32 weeks, check the bowel out again, see if it's changed any. The baby we had that had cystic fibrosis, it was echogenic at 20 weeks. We followed her closely, and by the time we were scanning her in the 3rd trimester, that baby had a bowel obstruction, and the loops of the bowel, it was so thick. You could just see the thick loops of bowel throughout there. So then we knew that this was more than just an isolated echogenic bowel finding. And that baby did end up having cystic fibrosis. And postnatally, depending on what you're finding, there could be a further workup, or again, if it's just isolated echogenic bowel and it's not from these infections or CF or chromosomal problem, there's no follow-up. You can notify your doctors, the NICU at delivery, but usually it's not concerning. And so it's often normal, not significant, but it can be associated with other things, as is anything with ultrasound. It's very subjective, which means that I could look at one baby and be like, that is echogenic bowel. My coworker could look at that baby and be like, that's normal. So it just varies from tech to tech to tech. And so that's why it's important that you have an experienced sonographer doing your scans and experienced providers that know the difference between these things, when it's concerning and when it's not. That wraps up echogenic bowel. I don't want you guys to leave. If you have had any of these findings, I don't want you to be scared or concerned about them until your doctor tells you that there is something concerning going on. Otherwise, like I said, these are just common abnormal ultrasound findings. So the next one we're going on to is renal pyelectasis, which is just dilation of the pelvic or central region of the kidney, where too much fluid just gathers into that little pelvis there. It could be called pelviectasis, pyelectasis, it's the same thing. 2% of normal babies have it. Can also be associated again with chromosomal problems. 18% of Down syndrome babies had this, and it can be associated with other pathology. Basically, if there's any type of kink in the ureter, or if there's an obstruction at the pelvic where the ureter goes into the kidney, then that can cause it. If there's a kink where the ureter goes into the bladder, that you get reflux back up into that kidney, and that can cause that also. Bladder outlet obstruction, things like that. In cases of mild dilation, the findings usually in an otherwise normal fetus with little implication, meaning that we see it, nothing you can do about it. And there's different measurements that we look at as techs. We don't want, in the 2nd trimester, it can measure, we want it less than 4 millimeters. But by the time you get to the 3rd trimester, it can be less than 10 millimeters. So obviously, as the baby grows, our numbers change. And so that's how we diagnose that. We're again going to look for other markers. If this baby just has the fluid in the kidneys, then we're just going to follow that. And 9 times out of 10, it resolves. If it is still there between 28 and 32 weeks, then we would wait, and this comes postnatally now. Once baby's delivered, we're going to measure, she or he will have an ultrasound of the kidneys once they're born to check those kidneys. So if this baby does have this prenatally, then you want to make sure your doctor, your pediatrician knows, so that way after this baby's born, you can get it followed up afterwards, and then kind of go from there with your pediatrician and your OB, and kind of come up with a game plan afterwards to find out what's going to be best for baby postnatally. It's generally an ultrasound finding that needs to be followed, but usually is of no significance. On ultrasound, we usually see that the plumbing of the urinary system appears to be a little backed up. That happens once, like I said, baby's bladder gets full. It just kind of refluxes back up into the kidneys. If it worsens, then we may need to do a follow-up. In addition, like I said, at birth, we'll just notify the pediatrician and get further studies done after baby's born to make sure that it's not, anything worse than that. That's usually it, though, as far as it goes with the kidneys. The next thing that we see a lot of is a single umbilical artery. So a normal umbilical cord has 2 arteries and 1 vein. So you get like a 3-vessel cord, and it has like a little Mickey Mouse shape. You'll see the 2 arteries in the vein. The 2 arteries are smaller, vein is bigger, and you'll see that in a cross section. I never recommend doing your 3-vessel cord in a cross section. Always look at your 3-vessel cord where it goes into the baby's belly and it splits around the bladder. Those arteries should go in and they should split around the bladder. On a single umbilical artery, you get this. So you get the artery going in on one side, and then the other side, it's not there. So you have a single umbilical artery or a 2-vessel cord, which means you have 1 artery and 1 vein. It is present in 1% of normal babies, 4% of twins, and in babies that just have the single umbilical artery, you're at an increased risk. There is no increased risk, I apologize, no increased risk of chromosomal abnormalities. So with the single umbilical artery, your doctor may recommend growth scans, because you are at a higher risk of having IUGR, which is intrauterine growth restriction. And then you just get growth scans routinely every 4 weeks throughout the 3rd trimester. And starting at 32 weeks is the recommendation. If it's an isolated finding, nothing needs to be done and there's no complications after baby's born. Rarely the finding can be a sign of a chromosomal problem or a sign that another anomaly exists. So because of that, a more detailed ultrasound referral to an MFM provider is usually recommended to diagnose that. But usually, again, these are just things that are not very concerning. Ventriculomegaly is a enlargement of the lateral ventricle of the brain, and there's different forms. You can have mild, moderate, and severe. Again, it can be unilateral, it can be bilateral. It's just more common, a normal variant, especially in males for some reason. I should look into that a little bit more and find out why, but a lot of these things are more common with boys. It can, again, be associated with Down syndrome. It can be associated with other intracranial pathology that can cause problems later on. So like developmental delay, injuries from the babies, infections, things like that. So things to do before baby is born. Again, we're just going to look for other markers, make sure that this is just an isolated finding. You can go for genetic testing to make sure there's nothing further going on. If it's severe, we would recommend an MRI of the baby, obviously in utero. So mom goes and gets an MRI and they can look at baby's brain a little bit better in detail through the MRI. Ultrasounds, what we call serial ultrasounds, just like routine ultrasounds every so often throughout the pregnancy, are indicated in severe ventriculomegaly. Postnatally, obviously depending on what the findings were on your workup, depends on what happens after baby's born. So ventriculomegaly is an ultrasound finding that can be of great concern, though it can also be considered normal. It can also be associated with chromosomal abnormalities as well as other brain abnormalities. So with ventriculomegaly, you can have mild to severe. Mild ventriculomegaly usually has no other problems and does not require further workup. If a baby has severe ventriculomegaly, then we definitely want to do further workup, and especially after baby's born, look into that a little bit closer. The next thing we have is club foot. Club foot is a malformation of the bone of the ankle, causing the foot to be turned in. So like here's people's legs that have normal legs. When you have club foot, your one foot, or you can have bilateral, your feet are turned in instead of a flat foot. And so this depends on how well the baby is cooperating, because a lot of times when babies are breech, they have their legs curled up and they sit like that. So their legs are curled in and it can look like they have club foot. But when they, readjust, turns out they don't have club foot. So that, it's harder to see further along, obviously, because the baby's getting bigger. And so that makes it a lot tougher. What do you do about it before baby comes? You are, again, looking for other markers. We're going to refer you to a genetic counselor if there are other markers. Postnatally is the biggest thing for after these babies are born. You are going to go see a pediatric orthopedist, and they are going to usually they cast these babies, and so they'll do it gradually. So they'll just slowly cast until those legs are straight. Might need surgery depending on the severity of the club foot. And they usually have a really good outcome. Our technology has gotten so much better, so these babies stand a better chance of having a more normal life after they have their little feet fixed. So again, just make sure that when you're looking at these legs that you're not catching the baby like in a breech position or in a position where their legs look turned in and they're not. The findings don't usually indicate that there are other problems, but we like to make certain of it by having a detailed ultrasound with a high-risk specialist just to make sure. Our next finding is a cleft lip. So cleft lip, it's I think almost everybody knows what that is. It's where you get the defect between the nostril and the upper lip. Again, it can be unilateral or it can be bilateral. It can include the palate. You can have a cleft palate without a cleft lip, but that's a completely different finding. And a lot of this is based off of ethnicity. Certain groups of people are more prone to these than others. If it's truly an isolated finding, cleft lip without the palate does not increase your risk of chromosomal problems. Cleft lip with normal chromosomes can be associated with other congenital anomalies. This one is hard, you guys. There's so many different numbers on this one. Prenatally, what do? We, again, are looking for other markers. We can refer to a genetic counselor. And then postnatally, again, like club foot, this is the biggest area. This is where we're going to get the most done. You're going to refer to an appropriate center. Usually it's like a craniofacial clinic. Plastic surgeons do these a lot, depending on the severity of the lip and the palate, determine if surgery is needed. Mild clefts, or if it's just the soft palate, usually there's no treatment. If it's a larger defect with the hard palate, then you're going to need surgery and learn how to do things differently once these babies are born. All right, guys, I hope that is some helpful information. Like I said, though, listen to your doctor, take their recommendations. They have plans in place already, and you really need to listen to them. And if you always are concerned and if you don't agree with what they're saying, get a second opinion. It's not going to hurt you. You can go see a high-risk specialist. If you do have anything concerning, just ask your doctor for a referral to see a high-risk specialist, and they can go over all of these things with you also. These were, again, just common abnormal ultrasound findings that we see routinely in the second trimester when you go in for like your anatomy scan. When I've said this, and I can't say this enough, when we just see it isolated, when we just see the echogenic bowel, when we just see the ventriculomegaly, when we just see renal pyelectasis, they're not usually concerning. It's when you start to piece these things together, and if this baby has all of those things, then that is more concerning, and then further workup is going to be required. If you guys have any questions, leave them down in the comments below. Any other video recommendations? I just know this was one that was highly, highly recommended. I've had multiple people ask me to do this. So I hope this is helpful. Again, I'm just an ultrasound tech. I am not a provider. I'm not a physician. I just love, love, love what I do, and I love to share all of the knowledge that I have. Thanks for watching, guys. I hope you're having a great day. Bye.